Good evening and welcome to tonight's webinar on protein concentrate, a vital element in regenerative medicine protocols. My name is Lauren Darren and I'm head of clinical education and managing editor for orthopedics at the Advanced Regenerative Medicine Institute, and I will be moderating tonight's session. Thank you for being here. We have people from all over the world joining us today, and it is a great pleasure to have Dr. Bert Mandelbaum with us. I'm going to make a quick introduction to him and then turn things over to his lecture. Dr. Bert Mandelbaum is one of the world's foremost experts in the diagnosis and treatment of orthopedic conditions, especially of those related to the knee. He practices at Cedars-Sinai Kerlan-Jobe Institute in Los Angeles, where he also serves as co-chair of medical affairs. His vast experience and skill are sought by some of the world's most prestigious athletic organizations. He serves as the Associate Chief Medical Officer for Major League Soccer, Medical Director for FIFA at the Medical Center of Excellence in Santa Monica, and is Co-Director for the U.S. Olympic Committee National Medical Network Advisory Group. He is a pioneer in many orthobiologic techniques and the co-founder and former co-chairman of the Biologic Association. Before we get started, please post any questions you have throughout the lecture in the Q&A section, and at the end, we will go through as many of those as we can. With that said, it is a great pleasure to turn things over to Dr. Bert Mandelbaum.
Good evening, Lauren, and thank you for that introduction. And good evening to everybody. And it's great to have a global audience talking about our family, our orthobiologic family. And specifically tonight, to have an opportunity to focus on one of the newest members of the family, alpha-2 macroglobulin, or as many folks like to relate to it as the protein concentrate. So with that, I really want to talk about where we are today. Where we are today is in personalized medicine. Some people have called it a personalized medicine revolution. It's about being personalized, predictive, preventative, and participatory. And our patients are really pushing us such that the market is really projected in an exponential way to grow, as you can see here. Now, everything in innovation, according to the innovation diffusion curve, really starts with one step at a time. The first is we see the innovators, as you can see here, and then comes the early adopters, about where we are today, and then comes the early majority, the late majority, and lastly, the laggards. But as we know, the steps up this exponential curve are quite steep and rigorous at times. So when we look at this orthobiologic family that we'll focus on tonight, we want to establish a level of perspective that'll give us ability for us to speak about. Now, one of the most important things for us to understand is that as of June 3rd, 2021, the FDA gave a consumer warning for all regenerative therapies and basically cordoned off an area where there were regulations and calling unapproved products, stem cells, SVF, umbilical cord or cord cells, exosomes, amniotic fluid, and Wharton's jelly, and limited us only to basically autologous products going forward. Now, with that in mind, I really want to get started with one of our athletes. So here is one of our athletes who presents. He's 25 years old. He has nothing really wrong with this left knee, but as you can see, there's narrowing of this joint space overall, and he's been having some soreness and pain. The elevator hasn't gone down, but is going down. So for us as clinicians, one of the most important concepts for us to think about is this really the teeter-totter between catabolism and anabolism and avoiding the progression of osteoarthritis going forward. Very important principle for understanding osteoarthritis. Now, these principles really started with Claudius Galen, who was the first sports doctor, surgeon, philosopher, and physiologist for Marcus Aurelius. And he said athletes overindulge, and guess what they get? They live shorter and they get arthritis. So this has been an age-old phenomena, but also a stereotypic phenomena, as you can see the results from Healy and Kutz's work of 2002 showing this progression of 1, 2, 3, 4 onto significant OA and osteoarthritis. Now, understand the complexities of the joint is to think of the joint as an organ, much like the heart. We must consider all details of alignment, the menisci, the ligament deficiency, but also complex molecular tissue, matrix issues in the bone, in the cartilage, the synovium, and what we now call the secretome, which is all of this, the interaction between the cartilage, the bone, the synovium, and how they crosstalk with one another going forward. Now, these complexities in understanding osteoarthritis are clearly above the pay grade for us orthopedic surgeons. But bear with me for a while, because I think it's important for all of us to understand so we could balance out our understanding of catabolism and anabolism. When you can see here the bone in relationship to the chondrocytes that have decreased in this situation of osteoarthritis. This aberrant remodeling, and there's cycles of cytokines that are significantly degenerative for the bone. Then the formation of osteophytes. Inside the joint, there's significant synovial inflammation, as you can see, and various pathways, again, cycling through the interleukins and TNF alpha, and then ultimately, there are other pathways that really are cycling off of one another. I'm going to pay particular attention to this one, the NF-KB pathway, which is extremely contemporary to understand alpha-2 macroglobulin going forward. Now, one of the things for us as physicians understanding, when we think about our population for men and women, about 35 million men and women have osteoarthritis in the US alone. And worldwide, it's exponentially greater. But if you happen to be someone who tore their meniscus, you could say they fall off the curve early in their 50s and get significant osteoarthritis. And if they happen to tear their ACL, they fall off even sooner. So for us as physicians, this group of patients right through here is really what we're focusing on. And why are we doing that? Because as you see from this longitudinal database published by Kahn and others in 2018, if you tore your ACL, you had a 7-fold greater likelihood of having a total knee, or tore your meniscus, a 15-fold greater odds of having a total knee replacement. So let's look at this normal OA curve and the mode of the total knee replacement. Perhaps futuristically, we'd love to be able to intervene with genes and do CRISPR and other technologies. If we could do that, we head out that curve. But that's probably way in our future. So let's look at what we have today. If you tear your meniscus, 15. If you tear your ACL, 7x greater potential of having a knee replacement. So what do we try to do? We want to disease modify to have a curve that looks like this. So everything we're doing in concept, technique, and technology is focused on those basic details as we go forward. So let's talk about this D mode, which is really a significantly challenged thing for us. Why? Because everything we've done thus far has been based on patient-reported outcomes, pain, function, and quality of life. Now, it's a new league when we're talking about disease-modifying effects, because we need to consider the underlying pathological or pathophysiological disease accompanying with significant changing in signs and symptoms, but also the biggest challenge to get this mark, to get this claim, requires a correlation between that clinical outcome, the PROs, and structural changes or biomarkers going forward. So that's a big lift to expect that we could achieve that going forward. But it is a goal. It's a moonshot for us that we need to focus on going forward. So let's look at the spectrum of care paradigm that we have in cartilage. We're not going to talk about prevention. We talked about these other comorbidities. Return to sport, we're not going to really focus on. But we are going to focus on minimizing the potential of OA and these two concepts of chondrofacilitation and chondroprotection going forward. Now, as I said, This family of orthobiologics is large. Everything from corticosteroids, glucosamine, HA, PRP, cytokine modulation, stem cell procedures, exosomes. Tonight we're focused on alpha-2 macroglobulin, amniotic fluid, estrogens, M2 macrophages, and M2 pathway inhibitors should be considered in this family going forward. So let's talk about what we know. Let's start simple. You know, our grandmothers told us an apple a day keeps the doctor away. What does all that mean? We know that apples help us, but they've taken out and they've looked at the apple procyanidins and found when you look at genetic target expression, that when you use these phytochemicals, these polyphenols, that we could turn on COL2A1 and ACAN, which are very anabolic genes to turn on. At the same time, these same polyphenols turn off the MMP3 and MMP13. So simple things in our diet can make a big difference going forward. Mike Giaccotti from Philadelphia looked at glucosamine in this systematic review and concluded that glucosamine chondroitin sulfate may protect joint cartilage and delay OA progression. And when we look at other things in our diet that people are using, melatonin maintains an anabolic equilibrium going forward in correlation when they looked at 11 trials in systematic review and meta-analysis, and it may contribute to this balance going forward and improving the vitality of the chondrocyte. And again, it's this balance that we're always going to talk about between catabolism and anabolic changes going forward. How about HA? Decrease inflammatory response, protects cartilage, and most importantly, as we've learned most recently in this network meta-analysis, in spite of the recommendations by the WIOS, we could see when we separate out high molecular weight HA from low molecular weight HA, in fact, what happens is it does meet the clinical important improvement, which is a threshold that when you put them together, they do not meet. And as a consequence, the Academy has frowned about the use of HA. But when you split it out using network meta-analysis, it's quite significant. If you look at the interrelationships between PRP and auger with MSCs, here we have those beautiful MSCs swimming towards PRP. They're summoned, and when they get there, they proliferate. They also have a significant positive effect on cartilage metabolism, regeneration throughout the secretome, which is really an important part of understanding all of these issues going forward. If we look at this going forward, we think about the balance, catabolism and anabolism, and we learn that PRP stimulates cell proliferation of osteoarthritic chondrocytes by potentiating SOX9 transcription and also elevating COL2A1 and ACAN expression. So again, a very anabolic, anti-inflammatory intervention going forward. How does it work? A load of evidence in all these articles, as you see. Take a picture of it, because those are the articles in terms of the mechanism of action, the evidence for the action. How about efficacy? You can see the list from 21 alone in terms of all the efficacy and the resultant findings that we see as a consequence of these studies in PRP efficacy. Now we're focused on the nuances, and I'd like to highlight some of those nuances, such as, does it make a difference if it's high white cell or low white cell? In this study coming from Milan, Italy, and Stefano Zavagini, they show that there's no difference between leukocyte-rich and leukocyte-poor PRP at 12 months in patients with KL2 and KL3 OA. Again, a nuance, but we'll have to see how that pans out over time. How many platelets do we need? In this particular study, they concluded that they need 10 billion platelets overall, which is crucial for a chondroprotective effect. Again, nuances, white cells, number of platelets, concentration, really important to understand this best. This comes from a study we're doing, we call the BARB study, where we're looking at the difference between responders and non-responders and look at the statistical difference between responders and non-responders with respect to the number of platelets going forward. A key point here that we've got to learn, and we've got to understand this going forward. And here comes from a study, a systematic review looking at low platelets, as you can see, red, yellow, and red, versus high platelets with respect to VAS score. As you get into the higher platelets, you can see green at 3, 6, and 12 months, meaning that the trend to now for evidence-based high platelets, better pain relief, better counterprotective effect going forward. Again, we'll continue our journey in looking at these nuances of how to find what works best and where. Adam Ants did an amazing job, and he found that when you exercise our patients before they give PRP, they have 20% more platelets, statistically different than those who did not exercise going forward. Simple things, apples, exercise can make a difference. And when we look now at adjuvant approaches, when we mix the HA and PRP, we find that HA induces those granules to release more TGF-beta and PDGF factors from PRP and makes it more efficient. And we know Brian Cole and his group, when he compared HA to those who've had PRP and HA, they had a greater improvement with PRP and HA. So we can see now the synergies and the adjuvant therapies going forward. When we look at the next step with respect to bone marrow aspirate concentration, we look at the rationale because there are some MSCs, but they're low in concentration. They're multipotential. They help with homing and cell migration and also have significant growth factors, including IRAP for differentiation and angiogenesis. The challenge is the numbers are low going forward. And these MSCs are really a challenge for concentration. So what are our concentration strategies? Well, we could have a simple centrifuge. We can get more complex and use a serial centrifuge, or we create cell culture. Now, everybody wants to know, because we don't have this in the US, the FDA doesn't allow us to do this. But when you expand these MSCs over time, you could establish a high concentration. You can get up to 20 million MSCs, and you could look at the number of cells that you get over time in terms of the expression and a 98% cell viability over time. So let's look at advantages, disadvantages, and similarities going forward. If we look back to another study by Adam Ants, we look at BMAC, and he compared it to PRP. And he concluded that BMAC was not superior to PRP. In another systematic review looking at BMAC, they looked at 8 studies, 299 knees, and they concluded BMAC is effective, but demonstrated no clinical superiority in relationship to other biological therapies. How about the approaches to stromal vascular fraction? You can see the fat taken from the abdomen here and try to associate BMAC to this, and they found there was no significant difference with respect to symptom improvement, but perhaps the stromal vascular fraction improved pain overall. Furthermore, when you look at this study coming from Julian Freitag, 329 patients with KL2-3OA, and found that adipose-derived MSC therapy is effective, safe, and long-lasting treatment. But when Alberto Gobi compared that treatment to combinations of PRP and HA, he found that there were no significant differences between adipose-derived cells and the PRP adjuvant combination. And again, what I'm focusing on is the nuances here of these interrelationships of our orthobiologic family for an understanding. How about, and this work comes from Carlos Leal from Bogota, Colombia, where they expanded cell MSCs, bone marrow derived, and compared PRP to high hyaluronic acid. And you can see the PRP over a 2-year period. It's in Spanish. And you can see here in green that when you take the expanded MSCs, they had a significant and dramatic effect of improvement over HA alone and PRP alone, as you can see here, from 3 months out going forward. And again, these are his studies, and we have to look at others like this one to truly understand that this one is published in AJSM, a systematic review from Tan et al. They took 19 studies, 440 knees. They concluded that intra-articular MSCs improve function for OA. Significant better outcomes from bone marrow derived. We saw the other studies that went the other way around. In this study, bone marrow derived were better than adipose. And they also concluded that the cultured MSCs were better than the uncultured. As we move across the ocean to Portugal from our good friend João Espargueira Mendes from Porto, we looked at 3 groups. The blue group, he gave a cortisone. The yellow group, he gave only MSCs, and the green group gave PRP and MSCs. And you can see here what they found was the combination, the synergistic combination between MSCs that were expanded and the PRP were the best group overall. So again, we're learning, we're building our knowledge to try to figure out where we go with all of these biologics in our family. Which brings us to the reason why we're here tonight. It's really to talk about alpha-2 macroglobulin.
Turning it into a trap. It costs a lot of energy to close a leaf. That's why they have multiple trigger pairs to prevent an accidental closure when hit by a drop of water or a falling leaf. Nobody knows exactly the mechanism they use to close their leaves, but it's hypothesized that it's due to a rapid flux of ions and water that move in and out of cells. This changes the shape of the leaf, turning it into a trap.
Yes, it's the Venus flytrap. And A2M is this amazing macromolecule, 720 kilodaltons, that acts like a Venus flytrap. And why does it do that? Because it's a broad spectrum protease inhibitor that's called a tetrameric cage. You can see 4 different legs to it. And what it does is it encapsulates these proteases and obstructs them, just like that Venus flytrap you saw, like that. And that's as a consequence, we look at it just like that. You see how it closes, and the biological forces do the same thing going forward. So how does this work? You isolate this, you put it in the joint, and the effect can be several-fold. First effect is that the A2M goes directly to the chondrocytes and has a very significant anabolic effect we'll talk about, but also you can see here how it skirts around and encapsulates these proteases, just like you see here. Here's the A2M, and again, tetrameric, you can see, but they also, just like the Venus flytrap, and they have those molecules inside the petal, they have these bait regions. As a protease comes by, look what happens. 1, 2, 3, and it closes just like the Venus flytrap, hence its effect. So what do we learn from that? We learn that A2M has a direct effect potentially on post-traumatic osteoarthritis by binding these interleukin-1 beta inducible mediators, and it acts through the NF-kB protein pathway. If you look further at this study, you find that overall what happens with the A2M, it decreases the levels of MMPs, TNF-alpha, and it neutralizes, as you saw, through those pathways. Let's take a look at this, how it truly works. If you look at the control, and now we're talking about the MMPs, and these are the catabolic parts of the equation, that in all of these situations, that with A2M, they're low. In this situation, the A2M is low. In terms of MMP1, you can see statistically significant than others, including the MMP3 and SMAD4, which was more positive. And again, it also concurrently increases the expression of COL2, type 2, SMAD4, and aggrecan. As you can see in this situation, the control is here and A2M is here. And the same is true for aggrecan as well as SMAD4. So the beauty of this intervention, it has a duality to it. It can affect catabolism. At the same time, it affects anabolism, and therefore is a great candidate potentially for disease modification. And again, as an orthopedic surgeon, when we look at these pathways, they're extraordinarily complicated. But the NF-kB pathway, as you can see right in the center, is really the gatekeeper for all inflammatory response in all cells in our body. And these complex interactions are really what the basis of potential inhibition of the pathogenesis of OA going forward. When we look at this study done in a rat model, we can actually see there's groups of ACL model where they transect the ACL and they use saline. And what you're looking at here is the amount of osteoarthritis when you transect the ACL and you just use saline. If you then transect the ACL and use HA, you see a little bit less, but not statistically less. But if you transect the ACL and use A2M, you almost eliminate all the OA. Not all of it, but you almost eliminate all of it. In the sham, you can see where the ACL is not transected in comparison to the other groups. And reflected in this, as we've seen, you can see here now, this is the anabolic side, when the groups of ACL transection with saline and HA is really low in terms of anabolic, but high and not statistically different than the sham with respect to collagen, aggrecan, and Run-X2 mRNA level. But on the catabolic side, MMP3, MMP13, and type 10 collagen mRNA levels are all statistically affected in this model. So we have a rationale for A2M and the protein concentrate for being great candidates. Now, part of what we're really talking about is the practical aspects of shifting and changing the progression going forward. And again, isolating these molecules is really part of what we're talking about tonight. And one of the things that I think that Apex has done very well is focusing on this protein concentrator. And it's not just the A2M, but it also has the potential of IRAP inhibition and other proteins that we further have to delineate going forward. This process of doing this is simple, and I wanted to show you a video of how it's done so we understand it better.
Apex Biologics is proud to introduce their exclusive industry-leading XCell protein concentration kit. The advanced features of the new protein concentration filter allow for increased concentration of a variety of beneficial proteins. This new filter allows for reduced processing time compared to other filters in the market. A new patented filter membrane allows for a larger range of proteins to be recovered and more water to be removed during processing, leaving an increased recoverable volume of protein concentration. Contact Apex today to see how our new XCell PT filter is the leading concentration on the market.
So, in conclusion, what have we learned tonight about our orthobiologics family? Well, first off, it is deep and steep. Orthobiologics are a complex family of potential interventions. And once we get into that, we clinicians have to understand a lot of complex mechanisms of pathophysiology, pathogenesis. Understanding how these things interact is really our biggest challenge going forward. We must understand the mechanisms. We must understand the evidence base regarding efficacy, safety, and precision going forward. And in the end of the day, for us, it's about how do we enhance anabolism at the same time we suppress catabolism. And mostly, again, as I said, the moonshot is about disease modifying. But again, that mark is really difficult to achieve, but our ultimate goal going forward. Our objective is always optimizing the chondrocyte viability. That's our goal. If we can keep that chondrocyte healthy, if we can prevent it from getting increasingly damaged, from dying, from chondrocyte apoptosis, then we're going to be better off. And we're learning now that where we're going from here, it's about using different parts of the family, adjuvant combinations, the synergies, the interrelationships. I think for the next 2 to 5 years will be really an imperative for us. Well, it's been great for me to really talk to all of you about this very exciting area, and I thank you for the time. And if there are any questions, please feel free to ask.
Thank you so much, Dr. Mandelbaum. I want to remind everyone that you can still submit questions in the Q&A section, but we do have someone that has asked if alpha-2 macroglobulin naturally found in synovial fluid and in what amounts?
Well, the big problem with that is that it's such a big macroglobulin that it's hard to find its way into the synovial joint, which is really the biggest challenge at a significant concentration. And I think that further understanding of those relationships is really important in getting a good homeostatic joint. So the big rationale is because the concentration is low, and that may be one of the pathogenetic factors. We need to learn more about that. But the answer to your question, the amount is too low in relationship to the inflammation. And when we create an imbalance of that favoring anabolism, that is the therapeutic rationale for using A2M and other interventions like PRP.
Perfect. When preparing an A2M injection, do you combine it with PRP or do you inject them separately?
Well, at the moment, we have several studies that are ongoing and looking at different things, that looking at PRP by itself, PRP with high hyaluronic acid. And my most challenging patients, we're looking at what I call the trilogy, where we're using all three at the same time. And again, those are for the patients that I call the rescue cocktail, the trilogy, that are the most challenging of all patients when other things. Remember, we're dealing in a climate where there are responders and non-responders. So if I have a patient that is a non-responder, I will use the trilogy, especially in someone that's an athlete.
Okay. Is this procedure with A2M a one and done, or does this need to be repeated at certain intervals?
I think it's a journey. And I do think that if we had the ability of turning genes on and off over time was a one and done, I don't think that's the case. And we're learning more that there's action, reaction, more inflammation, just like the study that we saw from PRP and leukocyte rich. Some argue that the response to leukocyte rich is actually more anti-inflammation over time as the second response. So one and done is not a concept. This is a journey. And I think ultimately we're going to develop schedules and algorithms for different patients at different times, depending on how they respond. But also, as we get better at understanding with our bio registry and biorepository studies, that we're going to have a group of patients that we're much more precise with, so that we understand how they will respond to PRP, how they won't respond to PRP, and why we need to do other things concurrently.
Okay, and do you utilize protein concentrate solely in the joint space, or is there benefit in using it in tendon, ligament, fascia, etc.?
I think it's a good question. I, at the moment, have not used it in tendon or fascia. I think there's not a lot of data in the literature at this moment. There's no question that there are mechanistic rationale for using it, but I think we need to have more clinical and also evidence that will help us understand how to answer best that question.
Okay, and looking at A2M in osteoarthritis, is it preferred to be used there and not post-acute injury, or have you seen evidence in that space as well?
Could you say that again? I didn't quite hear you.
Yeah, no problem. Is A2M best for just osteoarthritis or post-acute injury?
I think that's a very good question. You know, acute inflammation as a result of injury is complex. It's complex with respect to the macrophages, especially as they flip from macrophage 1 to macrophage 2. These systems are very complex, and I don't know the answer to the question at this point in time, exactly how, in response to injury, A2M, there's no question we know the mechanisms, but I don't know the efficacy as a consequence of that, because the inflammation is so stereotypically responsive to the injury, and where we treat that situation, whether it be early or late, are questions that we don't have the answer to at this point. If you look at the ACL transection study, it's an ACL transection and response and rat model, and you could see clearly that you could decrease a lot of these cytokines and these catabolic molecules at the same time turning on the genes. Now, how that gets done with respect to an ACL tear in a human, and when we do that, I think we may need to do more consensus building and have more evidence base to help us.
When looking at the, oh, go ahead.
Oh, that's it.
When looking at the reimbursement landscape, have you seen anything that looks like it's going to be changing as far as these types of injections being covered by insurance, or do you think it's going to be staying as a cash pay option?
Well, I think, probably the best classroom for me, we deal with a lot of athletes, and most of what I've learned back from 2007 forward has been in the athlete category, and I mean professional athlete category, because there, our workman's comp that manages professional athletes has been very associative with us. And so a lot of our experience came from working with the professional athlete. And then ultimately we're able to do it in the NCAA athlete through the secondary programs of the respective universities. And then, as you point out, the group of cash only. I think it's going to be a long while before we get a code for the orthobiologic family. We're suffering just getting a code for and getting it permitted for high hyaluronic acid, even though we point out, like I said, with that network meta-analysis showing that there was a significant difference reaching the threshold, we still don't have acceptance by a lot of societies and organizations. So with respect to others such as PRP and alpha-2 macroglobulin and IRAP inhibitors, I think we're a long way off from expecting that our payers to provide us with reimbursement in that regard.
All right, we had another clinical question that just came in. Do you see A2M being used or as a viable option in other joints such as the shoulder?
I think it does. The work hasn't been done. My partner, Mike Gerhardt, is initiating a study with A2M in the hip. Hip is a challenging joint because the proclivity to break down quickly and get osteoarthritis and require hip arthroplasty is the pathway in the elevator going down is very steep. So I think that would be a good testing ground for A2M, and I await the results of his work in that regard. Yes, I think the shoulder could be, but again, it depends on exactly what the stratification is, what the specific diagnosis is, rather than just using it generically in the shoulder.
Okay, and I think that's all that we have time tonight for questions. We want to thank you very much for joining us tonight, and thank you, Dr. Mandelbaum, for sharing your expertise on protein concentrate. We did want to let you know if you are interested in trialing protein concentrate at no cost, please email info@advancedregenmedinstitute.com. Thanks again, everyone. Have a great evening.
Good night, everybody.